Welcome to the Dr. Ed Show. I'm Dr. Edmund Sulkowski, and we are about health and wellness. You know, we never diagnose, nor do we treat, but we hope to educate and inform, empowering you to be in charge of your own health and wellness. We're going to have a fantastic show for you today. You know, healthcare is an interesting business, and it is a business. And the reason I stress education and empowering yourself is because you need to be your own advocate. Because you can go to a professional healthcare provider and they can say, well, you know, we have a medication that may suppress that symptom, but we don't really have a treatment for that. There's nothing we can do. You know, sometimes we need surgery, sometimes we need a little suppression of an inflammation process going on in the body, but there are other alternatives out there. And if you can utilize your own body to heal itself by supplying what it needs, you have a success as far as healthcare goes, in my opinion. And my guest today is going to be able to provide that to you for something that I think is so important, and that is your eyesight. There are some diseases out there that, oddly enough, the medical profession says the only thing we can do is treat a symptom. Maybe there's something more there. Let's welcome my good friend, Dr. Dennis Courtney, Pittsburgh's own Dr. Dennis Courtney. Dennis, welcome to
Dr. Ed, thank you very much once again for inviting me here.
You know, it's always my pleasure, Dennis, because you are about education. I'll just give a little background to the audience. You were a teacher before you became a physician, and actually we have doctors in front of our name. All that means is teacher. And also you continue to do that. You not only provide a service and treatment, but you educate your patients. And I think that's why we get along so well, because we have the same focus. And we have to provide treatments for issues that our patients come to see us for, but we also educate. You know, I'm often seeing somebody for something, and I'll say, well, you know, you could take this supplement and it can help do this, or, you know, if you stop doing this, it'll help do that. And you know, we're providing that little extra measure there. And eyesight is so important to everybody, and you don't realize it until it starts to fail. And there are a lot of diseases that affect the eye that really go untreated. And I have a lot of patients that come in and they say, I had one just a couple of weeks ago that says, I'm leaving your office, I'm going to get my eye injection. Well, that just gives me the heebie-jeebies just to know someone's coming into my eye with a needle. I give injections every day, you know, no big deal, but you're coming at my eye, big issue. So there are some things that we're going to talk about today that I think will pique a lot of people's interest because they're probably dealing with these eye issues. So I want to start off with, tell us a little bit about what's involved in the eye. I know we have a retina, I know we have a cornea, and we're going to talk about diseases of the back of the eye, which is the retina.
Correct.
But let's kind of break down that eye a little bit.
So the eye has three chambers. It has an anterior chamber, for which the most prominent component of it is the cornea. Disorders in the anterior chamber are virtually things that I can't help. This is the irregular curvatures of that cornea, and they're treated mostly by optometrists with lenses to bend the light so that it comes to focus directly on the retina itself.
So no one's going to come to you for a pair of glasses?
No.
No one's going to come to you for cataract issue?
I take issue with that.
Okay.
There's a mid-chamber, and the primary component of the mid-chamber is the lens. And with advancing age, it's quite common to have proteinaceous material accumulate on the lens that we refer to as cataracts. In fact, I can intervene in the reversal of those cataracts to be able to avoid surgery, which everyone would like to be able to do. When a doctor diagnoses a patient with cataracts, the conversation usually goes something like, well, right now I notice you have the beginning of a cataract. At this moment,
little
something beginning. But at this time, it's not, now here's the word used, it's not ripe enough yet to do anything about it. So I'll continue to monitor it, and at some point, when it's ripe enough, then we're going to have to remove that lens and put an artificial lens.
And sometimes that diagnosis and treatment is reasonable. I do that sometimes with decay on a tooth. You know, it's still in the enamel. We don't want to go in and treat it until it's in the soft tissue, the dentin. Sometimes it reverses itself or it stops and doesn't progress anymore if you do this and follow these procedures and so forth. So there is some methodology to that.
Yeah, there is. As I say, it's the most common eye disorder of all. I'm talking about development of cataracts. And quite honestly, the success rate of removing the natural lens and putting in a synthetic lens has a pretty good track record. I'm talking well into the 90% success. However, Dr. Ed, I have to contend with the people that don't have that success, because nothing is 100%, and certainly in eye surgery it is not. And what I've learned is, if this thing doesn't work perfectly, it works so lousy that the person is afflicted with this for the rest of their life. It seems like the ophthalmology world has one crack at it to get it right. If they get it right, all goes well. If they don't, all never returns to well ever again, and the patient becomes so disgusted and says, I can quote them, "Worst decision I ever made," continually plagued by symptoms from it, and there's no resolution. So before one has a surgery, I think our general rule is surgery should be the last resort.
Very last thing, yes.
Patients just aren't aware that there is another resort. And one of those things that can be done is to work with me, that hopefully is able to remove those deposits and at least, if not completely eliminate the surgery, delay it, postpone it considerably.
So you're not an eye doctor, but you treat the body holistically somewhat. In other words, you basically avoid medications, and you're looking at doing treatments that really support the body in healing itself.
The way I like to phrase that, Ed, is this. I'm a conventionally trained medical doctor. I had to learn everything that any of the doctors that your listeners and viewers had to learn in order to become licensed in the state of Pennsylvania. But really, the model that we are trained with in medical school is to take on a disease. We're supposed to choke it. We're supposed to strangle it. We're supposed to stomp on it figuratively through the use of either medications, surgeries, or procedures.
So that's what I call Frankenstein medicine.
Okay.
Yeah, I tell you that all the time. You chuckle.
So, but the bottom line is, you can never kill a disease with the tools found in conventional medicine. The only way you can do that in terms of taking on a disease is you can conquer it by promoting health, restoring health, and when you restore that health, tissue that isn't working right now begins to work again. And once it begins to work again, whatever those symptoms were, and in this case we're talking about your vision, you get a great gush and return of your vision and eyesight that you thought was lost forever. And by the way, the retinal diseases, let's get to that last chamber, the one I didn't talk about yet. That's the posterior chamber. And there's a structure in the backmost portion of the eye called the retina. The retina is where it all happens. There are nerve endings in the entire global portion of that retina that are able to be stimulated by light. And those nerve endings, of which there are billions, all send messages via a fiber to a nerve, because they all come together and form a nerve called the optic nerve. Yeah. This goes to the occipital lobe of the brain, which is the vision center of the brain. So if there are diseases of the retina, and let's be clear about what they are, because I think your viewers have heard them all. I'm hoping they're not afflicted by them, but very many of the people who are listening to us right now and viewing us are, but they come with the names of things like macular degeneration.
Wet and dry.
Wet and dry. Glaucoma.
Pressure.
Pressure problem. And by the way, of all the retinal diseases, this is the one that can and does lead to total black blindness. A third, very commonly now, especially with our generation being so predisposed to developing diabetes, type 2 diabetes, is diabetic retinopathy, because in diabetes, every organ is affected. There's not one single organ that's spared, and the back of the eye, the retina, is completely, the anatomy is completely destroyed, and therefore the vision ultimately deteriorates. And it's not, in any of these cases, there is no treatment. There is no treatment for the conventional medical doctor can use, the ophthalmologist, that can A, stop the further progression of the disease. So this disease is going to keep moving forward. We hope slowly, but we're not in control of it. And it could rapidly start moving and nothing can be done there. And there's certainly no treatment in the conventional medical world to back up and restore vision that is lost. So we have a very intelligent group of doctors that are hamstrung and hand-tied for being able to help. All the doctor can say is something like, well, unfortunately, ma'am, you have glaucoma. Now we're going to control the pressures to help some, but we cannot intervene in the disease itself. We'll continue to follow you, whatever that means, to watch you go down that hillside. And you are going down that hillside. And it's the scariest feeling, I now know, that one can ever have. Because I've had patients come to me and tell me, you know what? I'd rather die than lose my vision. And when I first heard it, I couldn't identify with that. It seemed like a very fantastic statement to me. With as many years as I have with these programs, I've heard that multiple times, and I think I can understand why.
Yeah. So you look at, let's say, macular degeneration, which they call MACD for short.
MACD.
And then you hear wet or dry. Tell us the difference between wet or dry MACD.
So all macular degeneration, and by the way, the macula is just the central portion of the retina. Parts of the retina have different names, and the macula is the largest single section of the retina. And anyway, it has the ability to deteriorate, and when someone is afflicted with macular degeneration, they lose their central vision and they maintain their peripheral vision. So they have what they call dark spots directly in front. They can't see.
So they can be looking at something directly in front of them and
they can't see it.
But they can see something
but
off
they
to
can
the
see
side.
it off to the side. Many times when they talk to someone, they talk to them like this, because they can see them looking at them this way. They can't see them directly on.
And there are other diseases that's a total opposite of. You can see straight on, you can't see the
And we'll
peripheral.
talk about that.
Yeah.
So MACD always starts out as a dry form, but in some cases, the destruction of the retina becomes so complete that it involves blood vessels which become very fragile and they bleed.
They leak.
They leak. And when they leak, that now converts this to a wet macular degeneration. There are injections that retinal specialists only can give by stopping bleeding through directly injecting through the globe of the eye right back to the retina. It sounds scary as all get out. I have patients that have to see their retinal specialist every month. They quake in their shoes. They know doggone well that when they go there, they're getting another injection, and it's just too scary.
Because it's just treating the symptom of it. It's not trying to reverse anything.
It will stop the bleed in a small area, but it does nothing to restore your vision. You're on a pathway to ultimately lose a considerable, what is small central then becomes a larger central involving only this very periphery working. You can't drive. You have your license taken away. You can have conversations with people. You know they're in the room. You see some image, but you can't see it. You can't see detail. So it's a very tragic set of circumstances. It's the most common of the retinal diseases.
And this MACD, whether it be wet or dry, is it age-related?
In fact, they referred to it as age-related macular degeneration. All of these diseases, except for a disease known as retinitis pigmentosa, that involves young people, people in their childhood and teens, but all other of the retinal diseases, they occur with advancing age. And it's because of certain things that have taken place over those years that ultimately leads them to manifesting this disease as they reach their aged years.
So does that have something to do with the diet, have medications that you've taken, alcohol, smoking?
You have now stumbled across what I believe to be the equation here. We are born with a genetic proclivity. We have weaknesses, each one of us in a different organ. Whether that ever manifests itself or not is determined by three factors. Number one, a persistent lack of nutrients which lead to deficiencies, nutritional deficiencies. Our diet is what our diet is from the time we're a toddler and live at home based on a whole number of factors: cultural, socioeconomic, availability. And so what you were lacking as a child, you continue to lack to this day because you eat the same diet now that you ate as a child for the most part. And so these deficiencies finally weigh in at some point, and it's usually as you're reaching your older years. And so one of the components for why people develop that visual disorder is that they had the genetic proclivity for it since they were born.
So we're talking genetics, and you're not going to do a lot to change genetics. I mean, they're trying, but we're basically talking the difference between genetics and epigenetics. And I think maybe for the audience's sake, that's like genetics is maybe the lock and epigenetics is the key. And if you don't put that key in the lock, turn the lock, it's not going to express itself. So something over our lifespan that we've done or not done has unlocked that code, and it's now expressed, and we have a disease process as a result of it.
I said there were three components. Very heavily, nutritional deficiencies are one of them. Naturally, in its treatment, we're going to have to reverse them. The second component, universal component, is the accumulation of toxic load over a lifetime.
That's an easy thing to accumulate these days.
Well, remember, we're all Pittsburghers. Some of us are old enough that we remember the old Pittsburgh, when you had to use a knife to cut the air because you couldn't see. And our steel mills are, for the most part, gone now, but we're still not known as having the greatest air of the various states and cities in the country. And so
part of that is, I think we're surrounded by these mountains, and we get that inversion all the time that it just lays there. It's why it's always gray.
Our geography provides us with the other element, which is we're accumulating these toxic substances over a lifetime. So cells that really want to work, they can't, because they're so blocked up with these toxic substances that even if they had a proper diet, which they didn't, the tissue can't work. Combine the two of them, we're well on our way to allow that genetic proclivity to be expressed.
So before the water can go down the drain, you got to unblock that drain before you start to treat
Exactly
that
right.
with the water flow. Okay.
So these two, I doubt in the alternative treatment world that they are ever ignored. I mean, you can't find help with your PCP or your specialist doctor. They have no training on nutrition. They know nothing about it. You won't get to first base if you're trying to have a discussion with your doctor about what your diet should be. Don't waste your time. Don't waste.
I had 5 days.
Okay. And likewise for removing toxic substances, we're not trained in that. That requires another level of expertise, which is going to be found outside the medical profession.
Well, basically, in allopathic medicine, traditional medicine, whatever you want to call it, if there's not a code for it, there's not a treatment for it. And,
Fair enough.
And you're talking about things that we have
There's
no
no
codes
code.
for. Yeah.
No code. I've stumbled across the third component, and I'm amazed myself in a way, because as I first entered the alternative world, I used to go to the conferences where the most well-known people that wrote the books were ahead of these organizations. They led the organizations. And so when the day was over and we were sitting around the bar having conversation, I, being a rookie, I just kept quiet. I mean, I'm very much.
That must have been really difficult for
Well,
you.
no, I was intimidated by their knowledge. They were so brilliant, and I had not learned much about this yet. And so I showed my ignorance by my timidity. So they kept talking, and they kept always talking about nutrition. And I learned a lot from them. And then another group of doctors would be talking about the toxicity issue and how you eliminate them. And it went back and forth, until one day I raised my hand sort of like this and said, "Hey guys, you got 1 and 2. What about number 3? And they said to me, "Hey doctor, whoever you are, what do you mean number 3? And then my response was, "What do you mean, what do I mean, number 3? As if to say, "You mean you don't know there's a number 3? And they actually had to admit they didn't know number 3. And I said, well, the absolute thing that makes this all work is an adequate blood flow. It is perfusion. If you don't have blood vessel activity that's vibrant, how are you going to get in your nutrients to the very cells that are starved from those nutrients? How do you think that happens?" And these brilliant doctors said, "Hey kid, you got a point there." And it said, "And by the way, you guys with all this expertise on removing toxic substances, how do you think that happens if you don't have a blood supply to carry them away, to carry those toxic substances away?" And they went, "Kid, I got to tell you, yeah, tell us more about number 3. So in an evening, I was elevated from a rookie to Socrates.
So one of the
Everybody
gang,
wanted
one of the
to
gang,
hear,
huh?
how do you do that? And I guess ever since, I've been able to maintain that.
So what are these toxic substances that you're talking about?
They're all the heavy metals, they're the lead, they're the mercury, they're the, from our dentistry alone back in the day, all fillings were amalgam. By definition, as a dentist, you know that 51% at a minimum is comprised of mercury, which is extremely toxic to tissue. And when talking about the eye, because there's only a 3 millimeter plate separating the roof of the mouth from the brain, we're in close proximity.
Yeah, what you're saying is not incorrect, and I'll define it a little further. Of course, like in our office, we haven't used mercury fillings for, I don't know, 30 years.
We don't use them anymore.
No, there are a lot of people still do. It's still
No,
out there
really?
being used. Yeah. But
Criminal.
I don't say a lot of people. There are still people that are doing it. They're still manufacturing it. I think my brother, Bill, Dr. Bill Sulkowski, was ahead of the game on the amalgams. and you know, it was toxic to the providers that were putting it in the mouths, right? And there were the old days, those dentists used to mix them in their hands and place them in the mouth. I mean, scary concept.
They don't come prepared. You have to mix them up.
Yeah, they're in little carpules and they have to be
Now,
shaken
is it
to
true?
combine.
Let me ask you a question. I've heard tell. So you prepare the tooth by creating an opening for that amalgam to go in. You turn away from a patient, you mix it up. If on your way to the patient you should accidentally spill it on the floor, is that not a spill that hazmat?
Well, I think in the old days it wouldn't have been, but today it would be.
Hazmat has to, you can't
Yeah.
wipe it up with a rag,
Yeah,
can you?
today it would be. But I mean,
Yeah.
you don't. In our office, we don't use this stuff. But just to further define this, because it's you know, I think pretty interesting.
I hit a
People-
nerve here. Go
Well,
ahead.
people I think will find it interesting. So the biggest part of that mercury exposure is when you place that filling or when you remove that filling. And the removal is secondary to placement. When you condense it, in other words, press it into place, that mercury-rich layer comes to the top and we scrape that away. We used to. You know, I did that in dental school. But interestingly enough, every time you chew, even on a 25-year-old filling that's amalgam, you off-gas a little bit of that stuff. So what I'm doing is kind of reinforcing what you're saying. You're getting that little bit of toxin every time you chew if you have silver fillings in your mouth. Everybody refers to them as silver fillings because there is a little bit of silver in there. I'm going to give them a little bit of credit. Because of that little bit of silver, they're very antibacterial and they help prevent recurrent decay from occurring. And that's wonderful. These new composite fillings don't do that. But those old silver fillings, and I've seen fillings that are 30 years old still don't have decay underneath them. That's pretty amazing. But they are toxic.
The damage that's done.
They are toxic substances. But you cannot, it's illegal, it's terrible. And you think about patients' benefits. If you walked into my office and I said to you, you got these silver fillings in you, they're fine, but you know, so mercury is toxic and let's take them out, I can get in a bunch of trouble for doing that. There has to be a reason for me to take them out. They're cracked, the margins are broken down, there's recurrent decay around them, you fractured a tooth, something like that. If I was just to take them out and say that, the profession would go bananas on you, or the powers that be, you know what I mean? So there's still this disconnect on patient health and
well,
care.
that's the controversy that exists within your own profession when you're trying to bill for this.
Oh, you can't for that reason.
That's right.
If you walked into my office, Dr. Courtney, and you said to me, I want all my silver fillings out, and we get a lot of your patients in our office, and they don't want those silver fillings in. I can take them out on their request, but they have to pay out of pocket for it.
Cannot bill for it.
Cannot bill for it.
Exactly.
You know, so we're off on a tangent here. Let's get back on focus over here. You got me going here. But so those toxins will enter and get in and block up those microvessels.
Yeah, they're extremely toxic to the function of tissue, and where they accumulate, that tissue can't work. We have to rid ourselves of them, and the art of being able to do so is an art that does not exist in the conventional medical training. So that promotes health. Medical doctors don't know how to do that. They're only trained on how to kill a disease, and they can't do it. So only doctors that know how to promote health can really help out and reverse many situations, not just the eyes. We're talking about them today, but that formula of step 1, correct all deficiencies, step 2, remove all toxicities, and step 3, optimize perfusion. I use that equation for anybody that walks in the door with any problem.
Actually, it sounds like step 3 should be step 1, step 2 should be step, you know.
There you go.
That's the way it sounds like it should be. Dr. Courtney, we're at break time. We're going to take a little break. We're going to come back and we're going to focus now. We've talked about MACD. We're going to talk a little bit about glaucoma. And then we're going to talk about what you can do to help reverse some
Fair
of these
enough,
things.
Dr. Ed.
We'll be back on Dr. Ed Show with Dr. Dennis Courtney. Welcome back to the Dr. Ed Show. I'm Dr. Edmund Sulkowski, and we're here with Dr. Dennis Courtney, talking about your eyes, that vision. You know, losing eyesight, losing hearing, those are all things that impact the quality and I think your longevity of life as well. I do want to remind the audience here, I'm going to take a second here to plug my radio show, Dr. Ed Show, on 12:50 a.m. The Answer, every Saturday morning, 9 o'clock, 9 to 10, live show. Also my blog that you can go to on rumble.com and spotify.com, and should be on iTunes and all of those. Just search Dr. Ed Show, and then you can subscribe and share. So with this MACD, last thing, and I know sometimes maybe they have to go in there to stop that bleeding and to try to slow down that progression, but you're going to talk about alternatives to really slow or stop it altogether.
Yes, we're going to heal that eye.
Let's talk about glaucoma a little bit. Why is that a problem? And do we know the cause of glaucoma?
In a sense we do, because the anterior chamber of the eye makes a fluid. It continually makes this fluid 24 hours a day. And there's an elaborate drainage system that allows the intraocular pressure to be maintained at low levels because we're able to get rid of that fluid. The system works beautifully for years. However, in glaucoma, what we have is the drainage system begins to clog up.
Is this part of your lymph system?
There's an elaborate drainage system, some of which involves the lymph, but they involve valves. When you talk about a drainage system, the word valve shouldn't be problematic for you, and these valves aren't working, and as such then pressure builds up intraocularly, and it becomes so great that the pressure of the inside of the posterior chamber, which is where the retina is located, ends up impressing itself, the pressure, on the very retina that's going to be processing this light, literally squeezing a blood supply from it, and as it loses its blood supply,
Tissue dies.
it doesn't work.
Yeah.
And it does. And so that process, we need the ophthalmologist to intervene, absolutely need them, to use eye drops to lower the pressure. They do a great job at that. I've never prescribed eye drops. I'm never going to. And I'm never going to interfere with an ophthalmologist and his selection of those drops. That's his world, and I'm thankful that he's able to intervene. But he can't do anything to get the vision back. And so we now can do so by following this protocol that I've put together, where we can be able to restore vision in a very short period of time, at least get it well on its way. Oftentimes, we're able to lower the intraocular pressure. As I say, I've never taken anybody off those drops, but we've seen the pressure lower so much that the ophthalmologist was able to take them off of the drops. And so we're very thankful that we have a method to help these people out that honestly they know nothing about, and it's shows like this that is a reveal to them.
So you mentioned diabetic retinopathy. Tell us what that is.
Well, of course, in diabetes, every organ is affected because atherosclerotic plaque begins to become deposited in every single blood vessel you own, no matter where that is. And this is why diabetes is a multi-organ destroyer. And as such, the heart, the brain, you just name the body part. The vasculature of that body part gets corroded with atherosclerotic plaque, minimizing the amount of blood flow to the area, and tissue just doesn't work. Well, that happens in the eye.
Because it gets starved, basically, starved of oxygen,
starved,
starved of nutrients.
And there's bleeding. You talk about wet MACD. Well, a very similar situation occurs in diabetic retinopathy because those blood vessels bleed too. Because the tissue itself is like paper. It doesn't able to behave, it's not able to behave like a blood vessel, and it leaks. And so those injections that you were talking about for the wet MACD, they're also used in diabetic retinopathy. Once again, not having a darn thing to do with improving your condition, only patch work to stop the bleeding. However helpful that is, that's great, but the person's vision is being lost, and sometimes rather rapidly, especially in diabetes. We find people in their 30s and 40s completely blind.
And diabetes used to be something you heard of. I remember growing up, well, they have diabetes. Maybe I knew one or two people, you know, and it usually was elderly people. It's younger and younger.
Oh my goodness. So, known fact in medicine is that the number one disorder of our generation and those that follow us is called metabolic syndrome. And in metabolic syndrome, due to high carbohydrate content and the inability for the cell to be able to process insulin correctly, you have plenty of insulin, you just can't get it to allow entrance into the cell of the foods you eat and the carbohydrates you eat. And so blood sugars rise, every organ gets affected. We're now at a point where it's, for the first time I can recall, the next generation behind us, for the first time, will have a life expectancy lower than their predecessor.
And it shouldn't be.
And that should not be.
Exact opposite.
With all this technology we have, should not be.
So in the years that I've known you, I know that you're an intelligent man, and I know you've been a motivated man. You don't go from being a high school teacher to a physician unless you have that motivation, that drive. So what motivated you to go from allopathic medicine, or what people go to their family doctor for, to more of a holistic physician?
Sure. So remember, by training, I'm an anesthesiologist. And if you would see the setup in the operating room that I work from, it's literally a Black & Decker tool chest with 5 drawers. And in those drawers, every IV medicine known to man is found. And during the course of an anesthetic, it's a beautiful art when it's able to be performed correctly. You're able to allow someone to have an invasive surgery with little, if any, effect on them. And over the course of my career, I used every drug in that drawer because I needed to. It was an unreal state to be anesthetized and to be able to have people emerge. The moment you walk out of the OR, which I call clean medicine, it has to happen. We need surgeons to do things. We're always going to need them to do these things. And they're going to work hand in hand and in concert with an anesthesiologist. We're a team. But the moment you walk into the hospital, I believe you now enter dirty medicine. Because every single thing that gets treated in there will never be cured. There is no fixes for any of these chronic diseases. You will be looking at your mortality and the issues that will lead to it, but there's no way that anything's happening over there.
Well, let me interject here. So, by the way, anesthesiology was developed by a dentist, so I just thought I'd throw that in there.
Throw that in there.
And second of all, you're looking at somebody who walked into a hospital and almost never came out, and I was thankful that they were able to do that, but they released me and said, we can't do anything more for you. And if I didn't have the same drive that you do and take it upon myself to look for the alternative way and the support of my body, I wouldn't be sitting here talking to you now, and that was almost 30 years ago. So, and you know the story. I'm not going to go into it.
Well, we won't need to go into the story, but I should interject. When it comes to acute medicine, there
Perfect.
is none better
Yep.
than what we have here in the U.S. and worldwide, as a matter of fact. But I use the word chronic medicine. That's a different animal. And we are terrible. We are lousy. It is embarrassing
Yep.
what we attempt to do by suppressing these symptoms and letting diseases progress.
So we could do like several shows just on that topic alone. So let's. So you went from an anesthesiologist to this more holistic approach. How did you develop? I know you're intelligent. I don't know if you're that bright. How did you develop the eye protocol? I'm joking.
There was an allure to me.
Okay.
I've been looking at this medical model of ours for a long time. Even while I was content in the OR, I'm looking at what's going on the outside, and it's bothering me. And it reached a point, literally, where there was a lure to pull me out of the operating room from a job that I really enjoyed to take on a job that's been a battle for me ever since. But I refuse to give in to the conventional medical world. There is a better way. People are now looking for doctors that do what I do.
They are.
We have the evening advertisements on our TV for every drug you can name, and the last 10 seconds of those ads will scare the bejesus out of anybody. And the public is going, hey, wait a minute. My doctor just put me on that medicine today.
Well, the idea is to go from a reactive to proactive. You know, preventative medicine is really what medicine should be. You have an accident, you have a heart attack, some injury, something like that happens, that's a whole nother story. You need acute treatment. But you came up with this eye program that nobody else in the country is doing. So how did you develop the eye program?
Well, let's be honest here. Remember me, the anesthesiologist. I'm not an eye doctor, but we owe a great deal of gratitude to an eye doctor that came right here from Pittsburgh. And
Dr. Edward Condrat.
And Dr. Edward Condrat was his name. He and his partner were well known in the world of ophthalmology when they were in practice. But Dr. Ed, a different Ed now, Dr. Ed Condrat, approached me in the late 1990s. And he said, Dr. Courtney, could you do me a favor? He said, could you please teach me what you do in your world of alternative medicine? And we have an unwritten rule in this realm of mine. I was taken under the wing of someone and taught, because there's no school for what I know. But I'm obligated to do the same for any colleague that happens to approach me. And I took his request and I taught him everything I could. He picked up on it, and he was an eye doctor. And so I didn't have an interest in pursuing the eye. I said, that's not me. I shouldn't go there. But Dr. Ed was an ophthalmologist. He took what I taught him and ran with it, and he perfected it. He then passed that art on to me. When he suggested that I go into these kinds of treatments, I said to him, Ed, I'm not an eye doctor. And he looked at me and said, why would you ever need to be an eye doctor? You're the guy with all the magic. You're the guy that taught me these very treatments. I've just applied them to the eye. You're the expert. And it made enough sense that the allure I became motivated. Ed brought me under his wing, taught me those protocols, and it's those very protocols that we utilize today.
Just a little aside, of course I know Ed Condrat, and one day he was in the office, and I said, Ed, I'm moving to Arizona. And he lived in Arizona, and he says, where are you moving to? And I said, I'm moving to Cave Creek, Arizona. And that's where he lived. I didn't know that.
Where he already lived.
And he said, well, I happen just to be moving out of Cave Creek and going to Florida.
Going to Florida.
But yeah, he's a good guy.
No, Ed did a marvelous thing there, and passing it on to me. What we were missing was a book. I didn't ever think I had a book within me to write, but I had that book within me, and so I have published a book.
Which I didn't bring. I meant to bring it today, but
All right.
you'll talk about the title and where people
Okay.
can get it.
But that is the manual that, when once read, backs up every single thing of what we have now, which are 3-day programs in our eye protocol, where we get people to come to us, yes, locally, but from all over the world.
You've had them come as far as Australia, my understanding.
She said it was 16 time zones. I never counted them myself, but I trust her. She went through 16 time zones to get here. Why did she come here? Because she was told by an Australian doctor that she had glaucoma and that he unfortunately wouldn't be able to do anything to help her, and that ultimately she can expect to go blind. Hit her in the gut with a full fist. But instead of whimpering away, she said no and hit what we then had, what was called the internet, and she found me. And I guess sight unseen, the allure to her was to travel all the way to Pittsburgh. It was the best move she ever made, because at the end of those 3 days, she had regained so much of her vision. Then, of course, when we're done with our program, they leave with all the equipment that they used during the 3-day program, and they now use that every day when they're back home to further improve their vision.
So are you just going by someone that comes in and you go through your we're going to go into detail about your 3-day program, but you have somebody comes in and they go through the program and they say, yeah, I can see better. Or do you have some way of quantifying that?
So the first thing I did when I started to offer these programs, I felt that anybody that was coming to see me deserved to be seen by an eye professional. So I went and found myself an eye doctor. And her name is Dr. Lisa Bowen. She's in a suburb of Pittsburgh. And the very first thing that happens is that every single patient that comes here for that program gets evaluated by an eye professional.
Before they ever see you?
Before they ever see me. She has all the machinery and the bells and the whistles. And so we're able to quantify where they are on day one.
She's getting a baseline.
She's got it all. Then they come back to me for 3 days, and I go through the various modalities. There are 11 different modalities that I use, okay? All day, every day, 9 to 4. And on Wednesday, if we started on a Monday, we roll up the rug at 2 o'clock, and we go back to Dr. Lisa to have her re-examine those patients. And it's there where...
So she's doing the same testing that she did on the first day on the last day.
Same day testing is repeated, and now we can document how much return of vision we have, and it is substantial. By the way, I don't think the patient is really much concerned with the quantification. They already know. They're seeing things that they couldn't see 3 days earlier. To have it quantifiable is really more important to me than to them. They know their vision is really on its way back, and they're going to follow my directions about what to do at home to gain even further use and return of normal to their eye. I never use the word, I can't use the word cure. I cure nothing. But what I'm able to do is introduce health to such a degree through those 3 steps: correct the deficiencies, remove the toxicities, and optimize perfusion. Let me say one thing right now that is important. Do you think I can replace the deficiencies of a lifetime in 3 days? Is that even possible? No way. It'll take a year or years. And the same thing for the toxicities. Am I going to remove all these toxicities? I am not. But through various electronic devices that I have, I will restore blood flow to the back of that retina in a nanosecond with the electronic devices that I have. And so I'm able to engorge the retina so much that I get restored function even with being under the duress of those same deficiencies still lingering and the toxic substances still there, yet to be removed. It'll take a long time to do that, but that perfusion is able to restore life in the tissue that hasn't seen life in a long time.
So
and that's why we have the results we have.
So it's a two-way stream there. It's taking things away and putting things in. Once you open that flow up.
Once I get that flow, then we actually can get nutrients in, which will take a while, and we can get toxic substances out, which will take a while.
So these patients have to keep coming back, or do they leave with devices?
They leave with their devices. We allow them to come back to be reevaluated at the end of a year and to see that they've maintained that. Some people never take me up on that. They live so far. The Australian lady never returned for a reevaluation, okay? But those that are local usually always do. And we're able to observe that they continue. And Dr. Lisa, who on my website, which is at pittsburgheyeprotocol.com, you actually have an interview with her where she expresses her cynicism. I mean, she was highly, she was not really believing that I could do what I said I was doing.
Because you know what you're taught.
Okay, because
right?
she was taught
Yeah.
that you can't do anything. Well, now listen to Dr. Lisa 15 years later. We have a completely different person. And she now knows that this is possible. And that's the most fun part of her month, is to be able to have my patients come through, because the other patients she sees don't get these benefits.
So I don't, but let's say I had MACD or I had glaucoma, and I wanted to investigate your protocols and talk with you. Do I just call your office and have a conversation, or what's the steps I have to go through?
You should go to my website. That website is Pittsburgheyeprotocol.com. Begin to scroll through the text, and will lead you to videos. There are 3 main videos I want you to see. One, you actually go attend a webinar, a lecture given by me on what the 3-step program is all about. My God, it's 45 minutes long. And so it's highly explanatory on what it is that this is all about. And we've only talked about it in a nutshell fashion today, but they can see a more elaborate version online. The next video is on testimonials. I've recorded many patients on day 3 and let them tell me what they felt happened to them. I really enjoy having people who have these diseases hear from other people what their experiences were. I think it's invaluable. And then the third video is a video of an interview of Dr. Lisa Bowen herself, the critical Dr. Bowen 15 years ago, and how things have evolved, where she openly states, no, these people have a substantial improvement in their vision in 3 days, and she enjoys seeing them. Many of these people, even though they may not live in Pittsburgh, only come back to her as their eye doctor. They fly in from wherever they're from, they see her, they see me, and they get on a plane by the end of the day and they go back home.
Yeah, when I lived in Arizona, that's what I did. All my medical care was a fly back here.
There you go.
All right, so you can see that we've got a couple minutes left in the show, so we gotta. You also hold seminars. You just had one.
Just had one. Intend to have many others. Call our office to find out when the next seminar will be.
And what's the office number?
724-942-3002.
And you'll talk to wonderful Kim, who will give you the
My office
information.
manager will enlighten them on whatever their question may be.
She keeps him in line, Kim does. And I'm happy to say that Dr. Courtney mentioned to me that his last seminar was packed with listeners for my radio show.
People that heard about me through your radio show. I want to thank you, Ed, for inviting me.
I'm glad that I'm able to do that because we want to help people. I think that's why we're here. You know, I think you and I have both been through some medical circumstances
We have had
that have changed us, and we want to pass that forward.
And help others.
And help others, exactly. Well, we're basically at the end of the show. It's always a fast show with Dr. Courtney. You can go to rumble.com. In fact, Dr. Courtney was a guest on the show last week, and I think that went up today, Dr. Courtney, on rumble.com.
Audio, the radio show?
So if you go Dr. Ed Show on rumble.com and search the Dr. Dennis Courtney, it should come up. And you can get some reinforcement. Of course, this I know gets archived and goes on YouTube and goes on Vimeo, so they can always come back to this too. And I think you're putting these on your website as well.
I'll put a link on my website that'll take them to it.
Yeah. So we're going to have Dr. Courtney back. I mean, he does a lot of other things too that are helping people. We're focusing on this eye stuff right now because this is something that really you can't get anywhere, and it's important.
I have no competitor.
All right. Thanks so much, Dr. Courtney, for being on the show. Remember, a healthy pet is a happy pet. When you're healthy, you're happy as well. And of course, my live show every Saturday morning at 9 o'clock, Dr. Ed Show on AM 1250 The Answer, 92.5 FM, archived on rumble.com, Spotify, and so forth. God bless. We'll see you next time. Bye-bye.
Bye now.